लगा रहा हूँ सर, लगा रहा हूँ, यही तो मैं।
Lalit boss, good evening.
Yeah, Dr. Hemant, very good evening. How are you?
That's fine, sir.
Thank you so much for joining in.
Yes, sir. Yes.
सब कुछ आ रहा है, स्क्रीन पे क्या है?
स्क्रीन पे कुछ नहीं आ रहा मेरे।
क्यों वो आ रही है उनको प्रेजेंटेशन?
नहीं। You are viewing webinars office screen. Hi Ashish, good evening.
Good evening, sir.
How are you?
Fine, sir. Fine.
Thank you so much for joining us. I think Dr. Lalit
Thank you, sir.
Sharma, Dr. Rohit has also joined.
Okay, sir.
Dr. Samir is there in. Dr. Hi, good evening. How are you, Lalit? Thank you so much for your hectic schedule and taking time out of your very busy schedule.
Good evening, sir.
It is a pleasure being with you, and it's always an honor listening to you, sir.
Thank you. No, in fact, it all is a joint effort, and we all, in fact, try to improve the hematology services and mainly the education part. In fact, whatever sitting in metro cities or big cities, we are able to do it. But our aim is to teach the students and the residents the basics so that they also develop and they also have some basic concepts of hematology as well as some oncology. And
Those two taking this humongous task and initiative, sir.
thank you. So, in fact, it all will be a joint effort by all of us. It's not that it is my personal baby. We all try, and I'm planning that we will have some curriculum, where in that curriculum we will develop the slide set and lectures. So I'm in touch with Professor Hemant Malhotra sir for that, And soon we will bring up the formatted hematology curriculum, where we all will be partnering for various inputs in the form of giving PPT, slide sets, then some video recorded messages, video lectures, and then ultimately we target that we will be able to reach to the more than 3,000 students of Rajasthan who are pursuing MBBS course, and later on we try that we reach to the practitioners as well. So this is how we plan.
That will be a wonderful learning experience, sir.
Thank you so much. So I can see Dr. Tamar sir has also joined, Dr. Mukesh Punjabi has also joined.
Hello.
Hello, yes sir. So Rupesh, can we start with your kind permission? So I think let us start now. It's already 7:30. We are live. So thank you all of you for joining and sparing the evening of hematology CME here today. I welcome all of you, and can you allow me to share my screen, please?
No.
Okay. So first of all, let me thank each one of you for sparing your valuable evening time for this webinar. And this will be a live webinar where we all try to help each other in understanding and try to make the residents understand the basics of myeloproliferative neoplasm. And we will be doing pH negative MPN today. I am thankful to my special guest today who has agreed, who will be joining soon. Dr. Ashok Jain will be joining us soon. He is Additional Director in Medical and Health Department in the blood cell. So now the government of Rajasthan has a dedicated blood cell where they are taking the education as well as service part of the blood related disorder. And thankful to Dr. Ashok Jain for giving us this opportunity and accepting our invite. Along with him, Dr. Satish Verma, who is Nodal Officer, and he is Professor of Internal Medicine, and he is Nodal Officer for Thalassemia and Hemophilia. He is currently Unit Head, and he is working at SMS Medical College Hospital. Thank you so much, Dr. Satish Verma ji. Professor R.K. Tamar sir is always an instrumental and guide to many of us, and he is currently Senior Professor and Head at Government Medical College, Kota. Thank you, Tamar sir, for accepting our invite and sparing your valuable time. Your participation definitely motivates us. Manish Chaudhary ji, who is the State Coordinating Officer in the blood cell, and he has been instrumental in guiding us about the collaboration of various government and non-government organizations. I am thankful to OncoNext Health Solution, who is the company who is helping us in bringing up this seminar here today. And I'm happy that we are having 19 institutes involved in today's discussion. So namely National Health Mission Swasthya Bhavan Jaipur, Mahavir Cancer Hospital, where Dr. Shashi Bansal and me are representing. SMS Medical College, thankful to Dr. Sandhya Gulati for accepting our invitation. Mahatma Gandhi Medical College, Jaipur National University, NIMS Medical College, SP Medical College, Bikaner, Dr. Pankaj Tantia will be joining us. Geetanjali Medical College, Dr. Ankit will be joining us. Government Medical College, Kota, Dr. Tawar has already joined. Manipal Hospital, Jaipur. Government Medical College, Jhalawar, two senior professors from pathology has joined us for today's discussion. Northwestern Railway Hospital, Dr. Manish Pabri, thank you so much, sir, for showing interest in this academic activity. SDMH Hospital, Cancer Research Center, Kota, Shelby Hospital, Precision Lab, Unipath Specialty Lab, Dayal Veena Diagnostic Center, Ajmer. Thank you so much, Dr. Mukesh Punjabi, for accepting our invite to be part of this meeting, and Metropolis Healthcare Limited, Jaipur. So I'm happy that gradually we will swell up and we will have more and more institute. And since this was our first exercise, we could not accommodate too many people, and we are trying that gradually we will build up our confidence. This is today's faculty. Let me introduce to the faculty today. Dr. Manish Pabri is senior consultant. He is head department of medicine in Northwest Railway Hospital in Jaipur. Professor Sandhya Gulati, she is in charge of advanced hematology and HLA lab in SMS Medical College Hospital, Jaipur. Dr. Rohit Jain, who is senior hematopathologist, and he is keen for the academic activities. He is from the Department of Hematopathology at SDMH Hospital in Jaipur. Professor Chetna Jain and Professor Rishi Diwan, both are senior professor from the Department of Pathology from Jhalawar Medical College, and I'm happy that they were also very excited and they agreed to participate in this meeting, and their residents and we all will be benefited with their expertise. Dr. Meenakshi Sharma is from Manipal Hospital. She is senior hematopathologist. Dr. Shashi Bansal, very good dear friend of mine, and almost 20-30 times daily we talk to each other. She is hematopathologist and flow cytometrist at Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Vishnu Sharma is associate professor in Department of Medicine. He is DM in hematology, and he is currently at SMS Medical College Hospital in Jaipur. Dr. Lalit Sharma. Again, we are blessed that we are having more power with having two Lalit Sharma. I am Lalit Mohan Sharma, he is Lalit Sharma. He is in Manipal Hospital. Dr. Hemant Dadich is senior consultant oncologist from Kota. Dr. Mukesh Punjabi is senior pathologist from Dayal Veena Diagnostic, Ajmer. Dr. Ashish is very good friend of ours. He is currently in Metropolis Lab in Jaipur. Dr. Pankaj Tatia, he is hematologist, practicing hematology, and congratulations, Dr. Pankaj, that you have proven that the government hospital setup also has got a potential to do bone marrow transplant. So he is the in charge for bone marrow transplant unit in SP Medical College, Bikaner, and Acharya Tulsi Regional Cancer Center in Bikaner. Dr. Ankit Agarwal is senior consultant medical oncologist. He is currently practicing in Geetanjali Medical College Hospital and Research Center, and he is also having keen interest in academics. Dr. Jitendra Pahaljani, he is senior consultant medical oncologist at Shelby Hospital in Jaipur. Dr. Sameer Agarwal, very keen pathologist, special interest in hematology. He is currently working with Precision Path Lab in Jaipur. Dr. Pankaj Malukani, very good friend, very senior hematopathologist. He is currently the director of the Unipath Specialty Lab in Jaipur, and he is very good in discussing the hematology cases. So I think we have come up, and at the end I want to extend my big thanks to OncoNext Solutions Private Limited, and these are the organizations where we have some collaborations. So with this I end up and I stop sharing my slides here. So I think with this I welcome you all, and can the team members confirm participations of our special guest, Dr. Ashok Jain, Dr. R.K. Tamar. Manish Chaudhary ji has joined, I can see him, and I can see Dr. Tawar also has joined. So Dr. Tamar, can you say few words, 1 or 2 lines, if you allow me for that? Dr. R.K. Tamar is there with us?
Sir, I am speaking. I am here. Good evening, sir.
Yeah, thank you so much, sir, for blessing us. Can you say a few words of blessing so that we can start today's session?
Sir, my blessings are always with you, and you are doing excellent work for the community. And regarding the diseases, we should have a team approach, and we should have personal communication with pathologists, cytopathologists, clinicians, and medical oncologists. So the treatment can be the diagnosis can be done as early as possible, so a treatment can be started. So these are my
Perfect. Thank you. Thank you so much. We take your blessings and move forward. That the diagnosis remains major challenge, because treatment part remains little easy for the clinicians, but the major challenge is with the pathologist to establish the correct diagnosis. Manish Chaudhary ji is also with us. Manish ji, thank you so much for joining us, and I'll appreciate if you can also say a few words so that we can start the academics. Manish ji, are you there around? So probably Manish ji is having some problem with the mic. So with this short introduction, we start with our first session. And since the MPN remains major challenge and pathological diagnosis of MPN remains the big issue. So with this, may I request Dr. Shashi Bansal, who is our first speaker, to be ready. And meanwhile, may I invite Dr. Manish Pabri, Dr. Sandhya Gulati. Dr. Manish Pabri is Senior Consultant in Department of Medicine at Northwestern Railway Hospital. Along with him, Dr. Sandhya Gulati. She is Professor in Hematopathology, and she is in charge for the HLA lab in SMS Medical College Hospital. Dr. Rohit Jain, who is the Senior Consultant in Hematopathology at SDMH Hospital in Jaipur. So may I request the chairpersons to start the first talk. Dr. Sandhya, please unmute yourself.
Is it okay?
Yes, yes. Thank you so much.
I welcome Dr. Shashi Bansal, as she's the senior consultant at Bhagwan Mahavir Cancer Hospital and a very good hematopathologist and a flow cytometrist. I request her to start the session.
Dr. Shashi, you will be able to share your slides, or you want me to project your slides?
I would be able to.
Yeah, you can share your screen. That will be great.
Is it sharing, sir?
Yes, yes, it is being seen. It is visible and you are audible.
Okay. Thank you. Thanks a lot, ma'am. Such a kind and nice introductions. And first of all, I thanks Dr. Lalit for giving me the opportunity to present this talk. Now, without wasting the time, we just started the thing.
Dr. Shashi, can you make it full screen, please?
Yes, sir.
Thank you.
Okay. So myeloproliferative neoplasms, my task is related to the diagnostic part, which is the root as it things which have to be very clear. So myeloid malignancy, as per WHO classification of 2016, include the MDS, MPN, or AML. But now we are going to concentrate on the myeloproliferative neoplasm. In this, there is very good things, BCR-ABL positive or negative. Once a BCR-ABL positive, its diagnosis is chronic myeloid leukemia. So we are not going to diagnose and discuss this entity. Now we are going to be the negative things. So negative include so many things are there. So which include the classic major forms, which is the primary myelofibrosis, which has the prefibrotic and the fibrotic stage, polycythemia vera, essential thrombocythemia, as well as non-classical and minor things, which always be. Am I audible? So chronic neutrophilic leukemia and chronic eosinophilic leukemia and MPN. So now let's start with the case profile. He is a 57-year-old male with a complaint of fatigue and lightheadedness and pruritus.
I think there is some disturbance, ma'am. You can carry on, ma'am. I think there is some.
It's okay?
Yes, it is visible. May I request everyone to please mute themselves so that the speaker can continue.
Okay. So now this in pictures. So this on examination, there is no hepatosplenomegaly, no other abnormality apart from the left findings, which has a hemoglobin 19.2 and the serum erythropoietin level below normal. So what is the differential and the provision diagnosis? This case is look quite simple because the hemoglobin is characteristically 90.2 with serum erythropoietin level below normal. So bone marrow finding is again supporting with the showing the hypercellularity with the trilinous hematopoiesis, decreased iron store and no fibrosis. Further supporting finding may be the JAK2 mutations and so which fulfill the criteria of PV with the evidence of erythrocytosis with the HB more than 16.5 in the male, bone marrow findings present of JAK and decreased erythropoietin level. For diagnosis which require all three major criteria or at least two major and one minor. So final diagnosis in this case is polycythemia vera. The key features confirming the diagnosis is elevated level of hemoglobins, hematocrit, hypercellularity of the bone marrow, and the decreased level of erythropoietin. If we look back, there is a JAK2 mutation is there, which is there in the major criteria. But the key feature does not include that. Why it is there? Because it shared by the other myeloproliferative neoplasm also. So major subcategory of PV, ET, and PMF, they all share the genetic mutations like the JAK2, CLAR, and MPL. They are not specific to these three. They can be seen in either of them apart from exon 12, which is specific for polycythemia vera. So they remain diagnostic issues. Diagnostic issue like how to differentiate ET from its mimic like the early primary myelofibrosis or PV, both of which can be associated with the thrombocytosis. So we have to differentiate between these three entities which share many of the same clinical manifestations like the splenomegaly, general symptom, microvascular symptom, thrombotic events, and hemorrhagic manifestation. Some has more, some has less, but they share the manifestations. If we see in the blood count, there is only the erythrocytosis is there, which is present specific in the PV, and anemia and thrombocytopenia, which is present in the primary myelofibrosis. But in the prefibrotic stage, there may not be any anemia or cytopenia. So they share with each other. But importance of differential diagnosis are highlighted by the distinct clinical outcome of MPN because if we see the overall survival is significantly better in ET as compared to the PMF, which has very low survival. So different outcome in the PMF and the ET result in the different treatment need. So they all are similar, but they have a different profile and different treatment needs. So we have to differentiate between these diagnoses. So inclusion of the bone marrow is important for the accurate diagnosis and differentiation of the ET and the primary myelofibrosis. So patient who was originally diagnosed as having ET were reassessed according to the WHO criteria and they are incorporating the bone marrow morphology. So once you incorporate, some diagnosis change. That's why the WHO criteria 2016 give much more importance to the bone marrow pathology. Because of that, it has been pulled out from the minor to the major criteria. So in the all the other major criteria, apart from the increased platelet count for ET and the presence of JAK, CLAR or MPN, it is mainly the megakaryocytic morphology, which has to be very specific for the ET, which has increased number mature megakaryocyte with the hyperlobulations. Like there is a normal to mild hypercellular marrow with the megakaryocytic prominence, which have the staghorn nuclei. There is a hyperlobulations with the staghorn nuclei, but there is no atypia. If we look for the diagnosis of primary myelofibrosis, we again have the splenomegaly and megakaryocyte proliferation, but specific is the atypia. So once there is the atypia is there, it is not the ET, it is not the PV, it is the primary myelofibrosis and associated with the myelofibrosis. So if we see The peripheral blood picture of primary myelofibrosis show leukoerythroblastic blood pictures with the teardrop cells, NRBC shift to the left, marrow is hypercellular with the megakaryocyte prominence and megakaryocyte atypia, as well as myelofibrosis. Myelofibrosis is a heterogeneous disease. So it has the overlapping features with the PV, ET, because the post PV MF is just post ET MF is there. So all these are overlapping is there, but we have to differentiate all these. So what is a major point of interest in bone marrow? If we see, it is mainly the megakaryocyte, which is a hallmark and has a crucial role in separating the different subtype of myeloproliferative neoplasm. Reticulum fibrosis or collagen fibrosis, as well as the immunohistochemistry as and when required. So if we see, the relevant factor for MPN diagnosis is the proliferation of atypical megakaryocyte with or without fibrosis. It is a major criteria for PMF. Hypercellularity with the trilineage proliferation is a major criteria in PV. Proliferation of enlarged, mature megakaryocyte staghorn nuclei, but without atypia is a feature of ET. So if you see the pictures, this is a bone marrow finding from ET and this is from primary myelofibrosis. Here there is a normal to mild hypercellular marrow with the proliferation of megakaryocyte and staghorn nuclei. But here it is the hypercellular marrow with megakaryocyte proliferation and atypia. There is a hyperchromasia, ballooning of megakaryocyte is there, which can be further appreciated on the high power view. The cells are, this is the nuclei which has the atypia. And here the cell atypia is not there, it's just the staghorn. Hyperlobulation of nuclei is there. So these two things has to be differentiated because they both have the different prognosis and different treatment need. But what about the minor MPN criteria? So when we see the minor B-cerebral negative MPN, it has the chronic neutrophilic leukemia, chronic eosinophilic leukemias, and unclassified. Let's have a case again. A 65-year-old male with the hypertension and diabetes, symptomatic from last 2 months, had the weakness, poor appetite, and weight loss. On examination, the hepatosplenomegaly was present. On investigations, it is a neutrophilic leukocytosis with the TLC 94,000, the platelet adequate HB 8.5. RBC has the normocytic normochromic, no 2-eardrop cells, and differential has the mainly polymorph. Shift to the left is very minimal, no basophilia, no eosinophilia, and creatinine and urea is on higher side of normal limit. So now we have know we are dealing with sub CMPD, but it is not a CML because there is no basophilia. It is not PV because it is not HB is increased. It is not ET because the platelets are not increased. Primary myelofibrosis always have more or less have the teardrop cells and the shift to the left with the leukoerythroblastic blood picture, but it's still out not there. So what is the things? If we see the picture, this is a peripheral blood which have the neutrophilic leukocytosis is the hypercellular bone marrow, which reveal marrow with the neutrophilic predominance without the feature of dysplasia. So hypercellular marrow with the neutrophilic predominance without the feature of dysplasia. Megakaryocytic series adequate in number and morphology. There is no atypia, there is no prominence, there is no pleomorphism, no excess blood, and reticulin stain is 0. And that persists the patient for 2 to 3 months. It has some PCMPD, but not specific. When we go for the chromosome analysis, this is not diagnostic. B-cerebral burn, which has to be ruled out at the baseline for proceeding for any MPN, was negative for all 3 transcript. Then we have to go for the JAK2, MPN, and CLAR. All 3 were negative. So this is coming the triple negative MPN. Then PDF GFR was also done, which were also negative. But one other investigation was also done, which gave the answer. That is NGS. So NGS gave the CSFR3 mutations. So that is the final diagnosis, chronic neutrophilic leukemia. So sometime we able to see these minor cases also where we know it is CMPD but not able to characterize. In their cases, the NGS give the diagnostic clues to what we are dealing. If we see the diagnostic criteria for CNL, The peripheral blood cell count should be more than 25,000, with the neutrophil plus the band neutrophil should be more than 80%. And neutrophilic precursor should be less than 10% of the TLC. Myeloblast should not be there, and monocyte count should be less than 1000. It is important to differentiate these cases from the chronic myelomonocytic leukemia. There is no dysgranulopoiesis. Marrow should be hypercellular with the neutrophilic granulocyte increase. Maturation pattern is normal. A blast is less than 5%. And it should not meet the criteria for other BCR-ABL positive MPN like CML or other MPN like PVET or PMF. There should not be any rearrangement of PDGFR, and there should be presence of CSFR3 mutation. If we are not able to see CSFR3 mutation, then it should be persistent neutrophilia for more than 3 months, splenomegaly, and no identified cause of reactive. And neutrophilia, including the absence of plasma cell neoplasm or the plasma cell neoplasm is present, and demonstration of clonality of myeloid cells. Now there is a MPNU. The MPN is a neoplasm that cannot be clearly classified as one of the other types, but it has a myeloproliferative features with a platelet count more than 4 lakhs, 4.5 lakhs, and TLC more than 13,000. The one as last is a chronic eosinophilic leukemias. It's considered the clonal eosinophilia and considers the presence of more than 1500 absolute eosinophil count in the peripheral blood that is accompanied by either the blast, more than 2% the peripheral blood, and 5 to 19% the bone marrow, or the presence of clonal cytogenetic abnormality. So that is the clonality in nature. In this case, if we go for the NGS, the studies have recently suggested that the possibility of reclassifying some case of hypereosinophilic syndrome to the chronic eosinophilic leukemia is there. So whenever we are dealing with any cases where there is a constant increased chronic eosinophilia, so NGS should be done. So what should be the algorithm? If we see the algorithm, whenever we suspect the myeloproliferative neoplasm, HB is increased, suspect the polycythemia vera, JAK2 mutations, then there is no need to go the further diagnostic screening. But if it is a polycythemia, if it is not the polycythemia vera, it is EG or PMF, then we have to use the bone marrow and the other mutations that has to be seen. All three mutations either are positive, it is MPN. But if it is all threes are negative, the triple negative MPN, then we have to see the bone marrow specificity and then reclassify the case. In addition, some mutation in the epigenetic regulator and spliceosomes are there. The list has been given, but they are also found in the other malignancy. Therefore, they are not specific for the diagnosis, but indicate a myeloid malignancy. So by doing the NGS and finding any of these markers is suggestive of the clonal nature of the neoplasm, but not specific for MPN. So whenever we are dealing with the triple negative MPN, we should go forward for the NGS to get any mutations to prove the clonality and the malignant natures. So although the mutation screening increasing utilized, but the morphology remain the central features because it will categorize the case either in the PMF, ET or PV in the case of triple negative. And ultimately, it is integrated clinical care to facilitate diagnosis, which we revert back, okay, the molecular profile is this. If it is triple negative, to reclassify the case and according to the clinical findings, you have to classify. So it is an integrated approach to classify the MPNs. Thank you.
So thank you so much, Dr. Shashi Bansal, for the insight and overview of MPN. I think it will be useful for many of us, especially clinicians and the students who are having problems in diagnosing and suspecting the MPN part. May I request the other chairperson to say a few comments and then we can move on to the second session. Dr. Rohit Jain and Dr. Manish Babri, sir.
Good evening, everybody. I think Dr. Shashi Bansal explained MPN beautifully, and thanks to her, I mean, we look more of such programs in future. Sir.
Thank you. Thank you so much. I think questions will be taken at the end of the session. And Dr. Manish Pabri has also joined, I think, and I can't see him. So anyway, with this, thank you, Dr. Shashi Bansal. Thank you, Dr. Manish Pabri, Dr.
Thank you,
Sanjay
sir.
Gulati, and Dr. Rohit Jain for your kind words. We will be having more interactions in the panel discussion and next time. So with this, I request the next chairperson, Professor Chetna Jain, Professor Rishi Diwan, and Dr. Meenakshi Sharma to start the next session and introduce the speaker. Is Dr. Chetna Jain around? She was traveling probably, so there might be some network disturbance. Dr. Chetna, are you around? Dr. Rishi Diwanji, are you around? So I can see Dr. Meenakshi Sharma. Meenakshi ji, can you unmute yourself and invite Dr. Vishnu Sharma?
Good evening, sir.
Thank you. Thank you so much.
May I request Dr. Sharma to please start the session?
So Dr. Vishnu Sharma is a very good friend of ours, and he is senior consultant in Department of Internal Medicine. He is DM in clinical hematology from prestigious All India Institute of Medical Sciences, and he is a new addition in Jaipur in the Department of Hematology. And Dr. Vishnu is very dynamic. Thank you, Dr. Vishnu, for accepting our invitation for this. And he will be discussing about the overview of MPN. Over to Dr. Vishnu Sharma. Screen is yours. Thank you.
Good evening, sir. Thank you for kind introduction. I'll be speaking on overview of prognosis and management of MPNs, particularly myelofibrosis, essential thrombocytosis, and polycythemia vera. So my MPNs basically divided into two mainly. One is BCR-ABL positive CML, and others are non-BCR-ABL positive or BCR-ABL negative MPNs. Because of the targeted therapy and specific molecular mutations which is responsible for CML. This CML is now basically not included in the list of MPN. So MPN has overlapping features including symptomatology, bone marrow findings, and cytogenetics and molecular mutations. It is important to differentiate between polycythemia vera, ET, and myelofibrosis because treatment is different and outcomes are also different. And it is very, very important to differentiate between ET and early MF or pre-fibrotic and myelofibrosis. So to differentiate between ET and early MF, bone marrow findings are completely different in ET and early MF. So these are the WHO criteria which has changed in 2016, and so this survival curve shows that survival of ET is almost comparable to the normal person, while in patients with early fibrotic or pre-fibrotic MF, survival is significantly lower compared to patients with ET. Same with progression to overt myelofibrosis, leukemic transformations, and rate of death. So these are the differentiating points. So marrow findings are important to differentiate between ET and pre-fibrotic myelofibrosis. So ET patient bone marrow shows myeloid hyperplasia, hypercellular marrow, increased megakaryocytes, but megakaryocytes are normal, mature, hyperlobulated, and Staghorn cells. While in patients with pre-fibrotic MF, marrow will be hypercellular, myeloid proliferation will be there, decreased erythropoiesis, and hypolobated or hypolobated megakaryocytes and megakaryocytic clustering. So marrow findings are important to differentiate between ET and pre-fibrotic. So as I discussed, this bone marrow is hypercellular in patients with pre-fibrotic MF, where in patients with ET it is normocellular. Myeloid proliferation is there, in patients with pre-fibrotic MF along with megakaryocytic clustering and hypolobated MAGs. So basically, myelofibrosis is a heterogeneous disease which includes full-blown myelofibrosis, pre-fibrotic MF, and post-PV and ET myelofibrosis. So to risk stratify patients of myelofibrosis, most commonly used scores are IPSS and DIPS and DIPS plus. So 5 variables are used in patient for stratification in IPSS, which includes age more than 65, constitutional symptoms, hemoglobin less than 10, WBC count more than 25,000, circulating blast more than 1%. And in patients for DIPS, we same variables are used, but for patients with hemoglobin less than 10, 2 points will be given. For DIPS plus scoring, these 5 variables are same, but 6 is platelet less than 1 lakh and unfavorable cytogenetics, which includes trisomy 8, -7, -7q, isochromosome 17q in version 3, -5 or deletion 5q, 5 deletion 12p or 11q23 rearrangement. So basically DIPS plus separates the curve more clearly, and IPSS is useful only at the time of diagnosis, while DIPS can be used in follow-up also. MySEC is used for patients with secondary myelofibrosis, that is secondary to PV and ET. These 5 variables were used: age at the time of diagnosis of myelofibrosis, and 0.15 point is given to each year. Hemoglobin less than 11 in IPSS and DIPS, hemoglobin value was less than 10, but in post PV and post ET myelofibrosis, hemoglobin value is less than 11 and 2 points will be given. Platelet count less than 1,50,000 and 1 point for this variable. Peripheral blood blast more than 3% and 2 points for this variable. Wild type CALR mutation 2 points, and constitutional symptoms, presence of constitutional symptoms given 1 point. So it divides into low, intermediate 1, intermediate 2, and high risk categories, and survival is superior in patients with low risk compared to intermediate 2 and high risk patients. So myelofibrosis is a progressive disease, and as the time progresses, patients goes into low risk to intermediate 1, intermediate 2, and high risk. And main complications and mode of death in patients with myelofibrosis is thrombosis and leukemic progression, and third one is bone marrow failure because of overt myelofibrosis. So risk of thrombosis at 3 to 5 years in patients with low risk disease is 3.3%, and leukemic transformation is 1.8% in 5 years. While in patients with intermediate 1 risk, thrombosis is 4% at 3 years, 5.4% at 5 years, and leukemic transformation is 4.2% and 5.1% at 3 and 5 years respectively. So it is higher in patients with intermediate 1 compared to low risk patients. These are the variables which are associated with poorer outcomes, like hemoglobin less than 12, platelet count less than 150,000, spleen size more than 5 cm below costal margin, liver size more than 2 cm below costal margin. So bone marrow fibrosis is also an important prognostic factor in patients with myelofibrosis, and progression of myelofibrosis implies advanced age, reduction of hemoglobin and platelet count, increase of WBC counts, enlargement of spleen, increase of circulating CD34 positive cells, increase in serum LDH, and worsening associated with worsening of survival. So myelofibrosis is a personalized disease which needs personalized treatment. So symptoms varies from thrombotic risk to thrombocytopenia associated with bleeding, extramedullary hematopoiesis, risk leukemic transformation, because symptoms because of leukopenia, leukocytosis, anemia, and systemic symptoms because of increased cytokine release and splenomegaly associated symptoms. So treatment of myelofibrosis according to NCCN 2018 guideline, low risk patient who are completely asymptomatic can be observed safely or can be enrolled in clinical trial. Patients who are in the low risk category and symptomatic can be started on ruxolitinib or interferon alpha, or can be enrolled in clinical trial. And intermediate one risk patient, if they are asymptomatic, can be kept for observation, or in symptomatic patient, ruxolitinib should be started, or in patients who had higher risk cytogenetic abnormalities or high risk molecular mutations can be subjected to allogenic stem cell transplantation, or can be enrolled in clinical trial. Intermediate 2 and high risk patients should be subjected to bone marrow allogenic stem cell transplant if suitable donor is available, or can be start if patient is not eligible for transplantation. Ruxolitinib should be started or should be enrolled in clinical trial. These are the different variables which are associated with rapid progression and poor survival. Spleen size more than 10 centimeter below left costal margin, time of myelofibrosis and ruxolitinib more than 2 years is associated with poorer survival, hemoglobin less than 10, platelet count less than 2 lakh, grade 3 fibrosis at the time of diagnosis, or lower doses of ruxolitinib are associated with poorer outcomes. Ruxolitinib, there are differences between rate of response between ruxolitinib and hydroxyurea. Splenic response was 57% versus 12% in patients who are started on ruxolitinib versus hydroxyurea arm. Improvement in symptoms was 78% versus 4% in Jakavi versus hydroxyurea. And in Jakavi arm, spleen response was seen in both driver and high risk mutations groups. So it nullifies the high risk mutations also. Selecting the right dose is important for best response. Patients who are started on higher dose, that is standard dose 20-25 milligram BD, has higher response in terms of reduction in spleen volume and also reduction in total symptom score. If platelet count is normal, patient should be started on higher dose, because lower doses are associated with decrease in the spleen volume reduction and total symptom score reduction. If platelet count is more than 1.5 lakh and patient is having anemia, then what to do? So if there is no anemia at baseline and hemoglobin is less than 10 after starting Jakavi, and patient is transfusion independent, should continue on same dose of Jakavi depending on the platelet count. If hemoglobin is less than 10 at the time of diagnosis and patient is transfusion independent or not requiring transfusion, start with lower dose 10 milligram twice daily. Or if hemoglobin is less than 10 at the time of diagnosis or patient is transfusion dependent, lower doses is recommended. So during therapy with ruxolitinib, if hemoglobin falls to less than 6, if during therapy patients develop drastic fall in hemoglobin that is less than 6, treatment should be stopped and patient should be observed and reinitiate therapy once the hemoglobin is improved. If hemoglobin does not improve, consider starting patients on erythropoietin, or you can add erythropoietin stimulating agents or blood transfusion with low doses of Jakavi and increase the dose as hemoglobin stabilizes. If the need for transfusion increases to twice weekly, discuss about the stopping Jakavi with patient. So another prognostic model which is used is MIPS and MIP70, which use hemoglobin less than 10 gram, WBC more than 25,000, platelet less than 100,000, blast more than or equal to 2%, fibrosis more than grade 1, constitutional symptoms, absence of KLR mutation, and high-risk molecular mutations, which include ASXL1, EZS2, SRSF2, IDH1, and IDH2, or 2 or more high-risk molecular mutations. So 2 point given to if patient has 2 or more high-risk molecular mutations, and 1 point for each variable. So high-risk molecular mutations This is mutation enhanced international prognostic model, which divides patient into low, intermediate, and high risk. And patients who has low risk, intermediate risk, and high risk have different survival. The low risk patient has higher survival compared to patients who has high risk mix. GIPS is genetically inspired prognostic scoring system, which use karyotype, which includes very high risk karyotype, which 2 points given for very high risk karyotype, and unfavorable karyotype 1 point. And driver mutations like type 1, presence of type 1 CALR mutations or absence of CALR mutation were given 1 point. High risk follicular mutations including ASXL1, SRSF2, U2, AF1 were given 1 point. So, survival estimates stratified by treatment molecular scores. Patients who are started on ruxolitinib have higher survival compared to best available treatment in patients with high molecular and low molecular mutations, low molecular risk mutations. Prognostic impact of driver and high molecular risk and non-driver mutations in primary myelofibrosis is also important. Patients who are CALR mutated have higher median overall survival compared to patients who are triple negative. Patients who are CALR mutated have a 17.7 years median overall survival compared to 3.2 years in patients who had triple negative disease. So analysis of association between set of non-driver mutations like IDH1, EZH2, ASXL1, SRSF2 and survival in patients with primary. Presence of mutation predicted decreased survival. That is more than 2 or more than 2 mutations predicts the worst outcomes, especially in patients who has triple negative disease. So risk factors for infection in myelofibrosis. So Jakavi is associated with higher risk of infections as shown in this figure. So various side effects which are observed in COMFORT trial includes fatigue, diarrhea, ecchymosis, peripheral edema, dyspnea, dizziness, and various kinds of cytopenias. There was no changes in the rate, distribution, or severity of non-hematological adverse event in the Jakavi group with long-term treatment. Most non-hematological adverse events were non-severe, that is grade 1 or grade 2. Atypical infections which are associated with Jakavi includes tuberculosis, hepatitis B, toxoplasmosis, progressive this herpes simplex and herpes zoster, which are higher in patients who are on Jakavi compared to best available therapy. So patients should be screened for hepatitis B, hepatitis C, or mycobacterium tuberculosis or herpes zoster at starting of Jakavi. Patients who are found to be hepatitis HBsAg positive should be started on prophylactic antiviral against hepatitis B, and monitoring should be done for HBV DNA. For hepatitis C, periodic HCV RNA screening should be done during therapy. For patients who are mycobacterium positive by quantiferon gold or other screening methods should exclude active infection should be excluded and consider isoniazid prophylaxis. Patients who had reactivation of herpes zoster in the past should be can be considered on acyclovir prophylaxis. So basically, Jakavi inhibits
Dr. Vishnu, can I interrupt you in between?
Yes, sir. Yes, sir.
Since most of the delegates logged in are students, so I'm requesting you to please focus mainly on the practical aspects.
Sure,
and
sir.
all high-end things. We will discuss something in the panel also.
Sure, sir.
Thank you. Thank you so much. Thank you.
Sure, sir. Sure, sir. So take-home message is basically myelofibrosis is a diverse group of disease which includes early myelofibrosis, overt myelofibrosis, and secondary myelofibrosis, and survival is different in patients with overt, early, and secondary myelofibrosis. And Jakavi is important drug which modify the natural course of disease and significant symptomatic improvement in terms of MPS associated symptoms and regression in the spleen size. Now come to the ET. Diagnostic criteria has already been discussed by previous speaker. So almost 60% patients with ET have JAK2 mutations, 20 to 25% patients has KLR mutations, and 3 to 6% patients had MPL mutations, and 5 to 15% patients were unmutated, that is triple negative. So in these, especially in these group of patients, reactive thrombocytosis should be excluded, because commonest cause of thrombocytosis is reactive thrombocytosis. Similarly, in polycythemia vera, JAK2 mutation is found, JAK2 V617F is found in more than 95% patients, and around 3 to 5% patients have JAK2 exon 12 mutations, and around 1% patients are negative for JAK2 mutations. So KLR mutation ET patients have lower rates of thrombosis as seen in these figures. Patients who are JAK2 mutated has highest risk of thrombosis, while KLR mutated patients have the lower risk of thrombosis. Disease progression in patients with ET according to WHO diagnosis. Patients, these slides has already been discussed. Clinical manifestations of ET includes most of the patients of ET are asymptomatic, and few patients presents with vasomotor symptoms in the form of headache, lightheadedness, syncope, atypical chest pain, paresthesias, libido reticularis, erythromelalgia, transient visual disturbances, thrombotic and hemorrhagic complications. Signs includes splenomegaly, abnormal blood counts, abnormal peripheral smear, hyperuricemia, thrombosis and bleeding. Survival in patients with because of survival in strictly WHO defined ET is near normal. 15-year overall survival is 80%, and 10-year risk of EML or MF progression is less than 1%. So no current treatment modifies the natural history of disease. As far as risk stratification in ET is concerned, it is divided into 4 categories based on age, history of thrombosis, and JAK2 mutations. So very low risk patients include age less than 60, no history of thrombosis in the past, and JAK2 unmutated. A low risk patient include age less than 60, no history of thrombosis, and JAK2 mutated. Intermediate risk includes age more than 60, no history of thrombosis, JAK2 unmutated, and high risk ET includes history of thrombosis or age more than 60 years with JAK2 mutated. IPSET criteria is used to evaluate the risk of thrombosis. It includes age more than 60 years, cardiovascular risk factors in the form of diabetes, hypertension, and previous risk history of thrombosis, and JAK2 V617F mutation positivity. So based on these variables, it is divided into a low risk, intermediate risk, high risk. So current treatment algorithm in patients with ET includes patients who are very low risk disease. That is, there was no history of thrombosis, age less than 60, and JAK2 unmutated can be observed safely. Or if cardiovascular risk factors are there, patient can be started on once daily aspirin, low dose aspirin. If patient has low risk disease, means there was no history of thrombosis, age less than 60, and JAK2 mutated. If there was no associated cardiovascular risk factor, should be started on once daily aspirin, or patient who has cardiovascular risk factor can be considered for twice daily aspirin therapy. Intermediate risk patients who has more than 60 years should be and no history of cardiovascular risk factors should be started on aspirin, or patients who has cardiovascular risk factor should be considered for hydroxyurea along with aspirin. High risk patients should be considered on hydroxyurea along with aspirin, or if patient has history of DVT in the past, should be started on systemic anticoagulation. So Choice of treatment include interferon alpha, hydroxyurea, or anagrelide, along with aspirin.
Dr. Vishnu, 2 more
yes,
minutes for you, please.
Yes, sir. So low dose aspirin is one of the mainstay of treatment in patients with low risk ET. Low risk scalar mutant ET without presence of any CV risk factor can be kept for observation alone. Cytoreductive treatment only should be considered for patients with high risk group or intermediate risk if risk of patients is more than 60 or mutated JAK2. Choice of cytoreductive treatment should be guided by age and history of thrombosis, platelet count. Now comes to the polycythemia vera. PV is the most common of the classic MPN, characterized by high hemoglobin, high hematocrit, associated with increased risk of thrombosis. Patient presents with neurological complications. Patient can develop neurological complications, microvascular or CV events, splenomegaly, or transformation to secondary MF or AML, or can develop MPN associated general symptoms like pruritus, fatigue, or microvascular and macrovascular complications. So diagnostic criteria has already been discussed. So PV symptoms are driven by a variety of causes. Can be because of increased production of circulating inflammatory cytokines, or can be because of hyperproliferative marrow, or can be because of hyperviscosity, which leads to headache, dizziness, skin rashes, vision problems, tinnitus, burning pain in the extremities, or splenomegaly and splenomegaly related symptoms. Physical findings include splenomegaly, which is palpable in around 30 to 35 to 45% patients with PV. It may develop in the early stage of PV due to excessive sequestration of RBCs, or in the later stage because of transformation to myelofibrosis or due to extramedullary hematopoiesis. Splenomegaly results in abdominal discomfort, early satiety, shortness of breath. Splenoportal mesenteric thrombosis is a relatively frequent complication in patients with polycythemia vera. Most often, PV is characterized by incidental discovery of high hemoglobin or hematocrit. Often, hemoglobin is not increased as much as the red cell count. Increase in the peripheral leukocytosis counts ranging from 10,000 to 30,000 can be present. Platelet count can be normal or more than 4 lakh. So, JAK2 mutation analysis is important. It is found JAK2 V617F mutation is positive in 96% of patients, and 3 to 4% patients will have exon 12 mutations, and 1% patients were negative for JAK2 mutation. Increased risk of thrombosis results from abnormal production of blood cells, increased viscosity, which leads to clumping of cells together. Fatigue and pruritus are among the most common symptoms in patients with polycythemia vera. The vast majority of patients with PV experience symptoms in the form of fatigue and pruritus. Fatigue is the most prevalent symptoms associated with polycythemia vera. Fatigue was reported regardless of disease severity and occurred in patients who lack complications of polycythemia vera also. So symptoms, most common symptoms is fatigue, followed by early satiety, inactivity, abdominal discomfort, and weight loss. So as far as the risk stratification of polycythemia vera is concerned, it is divided into low risk and high risk. Age less than 60 years and no history of thrombosis were categorized in low risk group, whereas patients who has age more than 60 or history of thrombosis were categorized in high risk. So leukemic transformation, polycythemia vera is a chronic disease with overt polycythemia can last for up to 10 to 15 years. In 10% cases, patients progress to post-PVMF. Rarely, the disease may transform to acute myeloid leukemia. 10 years risk of progression to post-PVMF is around 10%, whereas 5-year progression 10-year risk of progression is less than 5% in for acute myeloid leukemia. So risk factors for progression to myelofibrosis and AML includes high JAK2 allele burden.
Dr. Vishnu, may I interrupt you? Dr. Vishnu?
Yes, sir.
Can you please come to the summary slide so that we will have panel
Yes,
discussion and then we will take many issues. Thank you.
Sure, sir. So treatment mainly includes phlebotomy to maintain the hematocrit to less than 45% or low dose aspirin, and management of cardiovascular symptoms. Patients who are more than 60 years of age require cytoreductive therapy in the form of hydroxyurea, or who are intolerant to hydroxyurea or who failed to hydroxyurea therapy should failed for phlebotomy should be considered for hydroxyurea. So to summarize, PV is the most common of classic MPNs. PV is characterized by overproduction of blood cells, abnormally elevated RBCs, leading to thrombosis. JAK2, V617F and exon 12 mutations account for around 90% patients of PV. Thrombotic complications are major cause of mortality in patients with PV. Fatigue is commonest symptom. Splenomegaly is more extensive in later stage of polycythemia vera, and risk of transformation to AML and myelofibrosis is less than 10. Progression to myelofibrosis is less than 10%, and progression to AML is less than 5%. Thank you, sir.
Thank you so much, Dr. Vishnu. Your presentation has been of great value, and I was feeling like sitting in an international conference, honestly. Thank you so much for the vast and elaborative explanation about various aspects. And now may I request Dr. Satish Verma has joined here with us. Dr. Satish Verma ji, can you hear, sir? Professor Satish Verma has joined us. May I request him to please say a few words? He is a senior professor in Department of Internal Medicine at SMS Medical College. So I think he is not able to connect. May I request the last session, which will be on prognostic scoring of MPN by Dr. Lalit Sharma. And to chair this session, may I request Dr. Mukesh Punjabi, Dr. Hemant Adich, and Dr. Ashish Gupta to start the next session, please.
Yeah, I invite Dr. Lalit Sharma. He's a senior consultant medical oncology, Manipal Hospital, Jaipur. He will give his talk on pathological score of MPN. So, screen is yours, Dr. Lalit Sharma.
So there has been some mistake in typing. It is prognostic scores. It is not pathological scores. And Dr. Lalit Sharma, may I request you to be brief so that we can discuss in the panel discussion.
Definitely, sir, definitely. Good evening, everyone. At the outset, I would like to thank Dr. Lalit Mohan Sharma and the organizers for giving me this opportunity. And I would also like to thank the participants for sparing me their valuable moments. So I would like to keep my presentation very crisp and to the point, addressing only the prognostication scores. So as per the 2016 WHO classification, these are the various myeloproliferative neoplasia which we know of, but we would kind of restrict our discussion today evening to the more common forms of the polycythemia vera, essential thrombocytosis, and myelofibrosis. So first question which arises to a student's mind is, why do we need a prognostic tool in any particular disorder, and especially in myeloproliferative neoplasias? So there are multiple reasons to this. The first and foremost is that all of these myeloproliferative neoplasias are heterogeneous disorders. If you have 10 people who are having one particular myeloproliferative neoplasia, say myelofibrosis, each and every individual is going to behave in different manners, especially the most foremost factor which is going to determine the prognosis here is the molecular pathology which is driving that particular disorder. Over and above the molecular pathology, usually the age, the parameters at the time of presentation, they help us determine that what is going to be the future course of this patient, even with treatment and without treatment, which helps us determine the treatment strategy also. So the intensity of the treatment is based on the risk assessment which we do at the very beginning. People with low risk scores might be benefited with less aggressive treatment strategy, which is less toxic, and probably the treatment duration might also be curtailed. Whereas on the other hand, the patients who are lying at the other end of the spectrum and having high risk diseases would probably need aggressive treatment, more toxic treatment, and probably even with those, the response rates might not be that good for these patients. So the treatment outcomes, especially the survivals and the response rate, are basically determined by the prognostic tools in which strata these particular patients fit in. And they are now, moreover, there is a huge number of trials going on globally to look for how to improve the outcomes in these deadly disorders, so that newer molecules are being looked into. So we needed tools wherein uniformity of evaluation could be maintained globally. Different parts of the world might evaluate individuals by different parameters, and at the end of the day, comparison of those parameters might not be feasible. Last but not the least, especially in resource restricted settings such as ours, it might also guide us towards the allocation of resources, wherein we would like to allocate the resources more towards how in the more fruitful setting. Now, if we come to polycythemia vera, historically there has been a two-tiered stratification system wherein basically age and the history of thrombotic complications used to be looked at to determine whether the patients are low risk or high risk. Whereas in due course, the international working group also started including leukocytosis, that is a count of more than 15,000 at the time of presentation, to determine the risk assessment. But the most recent data showing the prognostic impact, such as the JAK2 mutation allele burden, or the cardiovascular risk assessment, or the high risk mutations such as ASSL and SRSF2 mutations, IDH2 mutations, they are not yet incorporated into the prognostic scoring systems routinely used in the polycythemia vera. So probably the answer to this particular problem, at least partially, was given by mutation enhanced international prognostic scoring system, that is the MIPSS for polycythemia vera. But this also has included only just SRSF2 mutation and not the other mutations. To summarize the MIPSS prognostic system for polycythemia vera, the different parameters which are being used is, one is age more than 67 years, and this is allocated 2 points if that is the case in the individual. And if the leukocyte count is more than 15,000, we allocated 1 point. If adverse mutations such as SRSF2 is there, now this has a very prime importance, and it is allocated the maximum 3 points, because this is probably the basic pathology which is driving molecular pathology which is driving the disorder. Thrombotic history is considered to be given 1 point. On the basis of this, if the patient has 0 to 1 point, they are allocated into low risk. 2 to 3 points are allocated if the patient is in the intermediate risk. If there are more than 4 points scored by the individual, the patient lies in high risk. Now, we can very well see in this particular slide, there is a huge difference in the overall survival of these patients. The low risk patients have an overall survival of around 24 years, whereas the high risk are not even able to achieve 3 to 4 years of overall survival. And mind you, this is the scenario in the most of this data comes from Western population. In the resource restricted setting, even patients with high risk would fare far poorer. Now, still, even with this prognostic system, there is an unmet need wherein the other mutations such as JAK2 mutation, cardiovascular risk mutation, and the high risk mutations are still not included in this particular system. Whereas in the case of essential thrombocytosis, the situation is slightly better, wherein other than age, gender, and leukocyte count, many of the high-risk mutations have been included. 2 points are being awarded for each mutation which is if present. So this probably gives an answer to one of the questions which was put up in the comment box also, or the chat also, whether we should go ahead with doing all these mutations upfront or not. Probably that is going to help us risk stratify these particular patients. Now, another disorder wherein these prognostic scores have been dealt with in detail is myelofibrosis. International Prognostic Scoring System, IPSS, was developed in 2009. But the problem with this particular score was that it usually used to, it had a restriction that it used to risk stratify at the time of diagnosis, and as the disease used to progress during the course of the treatment, we could not ascertain whether the individual is lying in the same risk group or has kind of progressed or the risk has kind of reduced. To answer this particular issue, of the dynamic IPSS was introduced, which which could be evaluated at the various stages of treatment, and if an individual is lying into one particular risk at the during the period of treatment, that used to also determine the overall survival, as we would see in the subsequent slides. Now, the latest prognostic scoring tool which is currently available with us is the mutation enhanced IPSS. This takes into account the most important factor in these disorders, that is the molecular pathology underlying these disorders, which is actually the driver mutation. Similarly, genetic inspired prognostic scoring tool, that is GIPSS, is also currently available with us. Mutation enhanced IPSS, the version 2.0 is the currently most used tool, especially in the majority of the clinical trials in myelofibrosis. Now, this is how the prognostic system has kind of evaluated in the myelofibrosis. Initially, IPSS used to assess only the individuals at the time of diagnosis, wherein age used to be accounted for, presence or absence of the constitutional symptoms such as weight loss, non-infectious fever, and night sweats used to be accounted for. Hemoglobin level less than 10 gram per deciliter used to be considered a bad prognostic marker, and the WBC count more than 25,000 used to be considered. Also was considered circulating blast cells. If they were more than 1%, they were considered to be bad prognostic marker. Whereas the dynamic IPSS allocated 2 points to anemia and 1 point to rest of the all other factors. And the advantage with the DIPSS was that even during the course of treatment, we were able to risk stratify the individual, and if the individual was into the low or the intermediate one risk group during the treatment, the prognosis seemed to be far better and the curves seemed to be separating more widely. Coming back to the previous slide, on the basis of the IPSS, you can very well see here that there is a major difference in the median overall survival of in the tunes of that the low risk patients would survive for anywhere around 11 to 12 years, whereas the high risk patients would survive only 2 to 2.5 years. So here lies the importance of prognosticating these patients from the very beginning, so that we could resource allocate and we could determine the treatment strategy from the very beginning. Other than the prognostic scoring tools, even in the one particular risk category, especially the low risk myelofibrosis patients, individual parameters also had different could predict worse event-free survival. One of the very important one is the hemoglobin at the presentation. If an individual is having hemoglobin less than 12 gram per deciliter, it is considered to be a poor prognostic marker. So is a platelet count of less than 1,50,000. Spleen size is an independent risk prognostic factor, and so is hepatomegaly. As the volume of spleen increases at the time of presentation, poorer becomes the prognosis of the individual, and the need for more aggressive and prolonged therapy is kind of probably indicated in such individuals. Thank you so much for your patient hearing. I hope I have addressed the issue within time. Thank you so much, sir.
Thank you, Dr. Lalit, for nice presentation.
I request Dr. Mukesh Punjabi and Dr. Ashish Gupta to say a few words so that we can proceed to the next session, please.
Thank you, Dr. Lalit, for a wonderful talk. You have put up the importance of the molecular markers in the MPN and further its importance in the prognostic scoring system very beautifully, and also answered one of the questions which I've asked for the mutation enhanced prognostic scoring system. Thanks a lot.
Thank you so much, sir.
Dr. Mukesh Punjabi, do you want to say something? So I think with this we conclude the session on prognostic. Thank you so much, Dr. Lalit Sharma. And I think you have shown clearly the importance of very small factors which is available in most part of the country and Rajasthan, like taking example of age, the importance of thrombosis, history of thrombosis. We have seen the role of a proper examination, liver and spleen size, increasing spleen size. You have mentioned about the role of hemoglobin, WBC platelet, and the blast cell. So obviously these all are very basic, and we are here to discuss all these things. So next we will be doing a panel discussion. Professor Satish Verma ji is here. I'm just waiting for Professor Satish Verma sir also to say a few words. I have seen him few minutes back. Professor Satish Verma ji, are you there? I think we are not able to connect to him. Professor Satish Verma ji, may I request you to say a few words? If you need to unmute yourself, sir. Dr. Satish Verma, sir, you need to unmute yourself, sir. May I request the backend team to unmute Dr. Satish? Yes, sir, now you are unmuted. Thank you.
Wonderful session, and everybody has delivered the best possible view, and such webinars are very important from teaching point of view and from learning point of view. We are also at the stage of learning also.
Very true, sir.
Thank you very much.
Thank you so much, sir, for your kind words. And we are, in fact, blessed, and we feel more powered by a senior person like you joining the event. In fact,
you know, everybody, you know, everyone is in the stage of learning. Absolutely. At any stage of the life.
Very right, sir. Thank you. Thank you so much, sir. Thank you for your kind words. So with this, may I end up this session with the kind permission from the chairpersons, and we'll be moving on to the next session, which is panel discussion. And I will be moderating, and may I request the team to allow me to share my screen. I think you all can see my screen now. It is visible to you all. And the panel discussion, first of all, again, once upon, I would like to thank the OncoNext Health Solution and the Partnering Institute and happy that around 20 different institutes, which are medical college, non-medical college, and various organizations have joined us today. And this is just the beginning. I am very hopeful that from next meeting onwards, we will be having more and more of organizations and consultants joining us. And thankful to all the consultants and faculty who has taken pains to join us. I thank more than 100 delegates, students and participants who are there for last 1.5 hours to listen to our discussions. Now, may I request the panelists. Today's panelist is Dr. Pankaj Tatia. Dr. Pankaj Tatia is Senior Assistant Professor in the Department of Medical Oncology and Bone Marrow Transplant Unit. Dr. Pankaj has already done bone marrow transplant at SP Medical College, Bikaner. Thank you, Dr. Pankaj Tatia, for joining us. Dr. Ankit Agarwal is Senior Consultant Medical Oncologist at Geetanjali Medical College. Dr. Jitendra, very good friend of ours, very young, dynamic person. He is working at Shelby Hospital in Jaipur. He is a Consultant Medical Oncologist. And these are two eminent pathologists. Dr. Samir Agarwal is at Precision Lab in Jaipur, and Dr. Pankaj Malukwani is Lab Director in Unipath Specialty Lab in Jaipur. So with this panel, I am moving to the direct case. So I am discussing case number 1, and I am requesting all the panelists to please restrict to the very basics so that the students can take home some useful messages. We don't want the high-end things, and we want the discussion to be very practical. So this is 52-year-old male presented to us in September 2007. Giddiness, weakness, fatigue, transient blackouts for 3 to 6 months. Outside, somebody has seen, and the examination revealed a liver and spleen of 6 and 8 centimeter respectively. This was his CBC, 17.1 hemoglobin, TLC 27,000, platelets 4,23,000. So now may I start with my panelists that how do we go ahead with such kind of issues. So may I request with Dr. Pankaj Tatia that Dr. Pankaj, what is your message if somebody sees this report sitting in peripheral areas of Bikaner? What next he should demand?
Thank you, sir. Yes. Thank you, sir, for the opportunity. I think we should go for PBF and a good bone marrow aspiration and biopsy. Also, we can go for a mutation analysis too in this kind of patient. As we have got splenomegaly, hemoglobin is more than 16.5.
Yes.
And TLC is also raised. So he might be a case of high risk polycythemia vera.
Absolutely. So the next investigation which is there, PCV is 62%, uric acid is high, LDH is high, serum erythropoietin has been done, which is normal. So, Dr. Pankaj, you are there, and if you get this report, next, what will be your approach? How do we go ahead? The relevance of investigation with practical approach.
Sir, serum EPO level is not a major criteria in polycythemia vera as per WHO classification in 2016. So we should go for a good bone marrow aspiration biopsy and a JAK2 mutation analysis. Or we can opt for a MPN reflex panel.
Perfect.
Okay. One more thing we can consider, we can also go for a BCR-ABL test too.
Right, very right. Dr. Ankit is here. Dr. Ankit, you agree to this, or you want to say some practical pearls to students that how should they think and how should they approach?
So one thing I would like to tell the students is whenever we see elevated hemoglobin, there are certain things that should come to our mind. Basic reason why serum erythropoietin basically was done is to rule out any tumor that is secreting erythropoietin that might cause elevated hemoglobin. Now, one more thing that should come to the mind is because the TLC is also elevated, there is certain, there should be some bone marrow abnormality that is causing all these problems. LDH is so high, uric acid is high, and hematocrit is very high. The patient has a good risk of going for a thrombosis. So the person should undergo a bone marrow testing to confirm what all things are going on in the bone marrow and confirm the diagnosis of polycythemia so that appropriate treatment strategy can be started on.
Perfect. So thank you so much. So the bone marrow test has been advised for this patient. Bone marrow, may I ask Dr. Jitendra here, Dr. Jitendra, will you advise for aspiration or you will ask for bone marrow aspiration biopsy?
Sir, I would like to do a good biopsy, at least 1.5 centimeter or 1.25 inch, to see the fibrosis basically and the cellularity in the marrow.
Dr. Samir, do you feel that anytime we are doing a bone marrow aspiration biopsy, should we keep some sample for further testing if needed any?
Yes, sir, absolutely. We should keep the sample in EDTA and heparin so that if we have any surprise that comes up, maybe flow or any other karyotyping or any other investigation that can be done.
I think that is very important message which Dr. Samir has given, that whenever you are doing a marrow, we should keep some sample in EDTA and heparin so that this can be used for further analysis if needed. So we move forward, bone marrow biopsy, and we will not discuss about the details of prevalence and other things. We will not discuss. So coming to our next thing, this was the reflex panel advice. Since the pathologist with us is very learned, Dr. Shashi Bansal, she immediately told us about that you do the MPN reflex panel injective mutation. While waiting for the reports, may I ask Dr. Pankaj Tantia that Dr. Pankaj, how should we manage this patient? You have done the test, the reports are awaited. But what are the important risks with high hemoglobin, high hematocrit? And what do you tell our residents that how should they go ahead?
Sir, in this patient, we should start hydroxyurea and allopurinol or any other drug for decreasing serum uric acid level. Also, we can go for a phlebotomy for a while, so that patient should be asymptomatic within 24 hours.
Can you tell the residents clearly that what do you mean by phlebotomy?
Phlebotomy means we have to take out 300 ml, at least 200 to 300 ml of blood, and at the same time when you are taking out blood from the second hand, you should go for a D5 500 ml story for the replacement fluid. The procedure should be done always in blood bank setting only.
Right. So agree that it is like a blood donation, that you go to the blood bank and you
but
give
you can't
your
use that blood for donation because
very right.
That's right.
Absolutely right. So the next question, which I think is not relevant today, quantitative, qualitative, and the important point here, may I ask Dr. Pankaj Malukani that sitting in clinics, we are coming across with various labs. So sitting in any clinic, how do we establish and how do I judge that which lab is good for JAK2, MPN and other molecular tests, which Dr. Vishnu and Dr. Lalit Sharma has already mentioned?
Sir, this is just in my opinion, and because you asked this question to me. So, first thing, we should see that who is interpreting these reports for us.
Right.
I mean to say, like, particularly if we're talking about hematological malignancy.
Right.
So, the person who is interpreting this report for us should be a good morphologist also. So,
Right.
for obvious reason, he has to be a molecular pathologist. Or if there is some place where the morphologist and the molecular biologist, they are working in close coordination.
So can you suggest, Dr. Pankaj, if in between I'm interrupting just for the benefit of students and shortage of time, if somebody is sitting in Jhalawad, what do you advise that how should they collect sample of marrow and how do they transport?
Sir, they can transport the way we do aspiration, we collect the sample in EDTA and a heparin vial, and we can keep those vials in the blood box, that is a thermocol box, and with ice pack, and we can transport that in bus or anything else to the concerned lab. And they generally those labs are promised to take these samples from the site of delivery.
Perfect.
Within 24 hours, if the sample is reached to that lab, they can transport that sample to the concerned laboratories.
So coming back to our patient was JAK2 positive, BCR-ABL was negative, serum erythropoietin as mentioned was normal, and phlebotomy was advised, and hydroxyurea, as Dr. Pankaj has mentioned, we have started 1 to 1.5 gram daily, and the requirement of phlebotomy or the hematocrit was coming down, the hemoglobin was also coming down with the repeated use of hydroxyurea and phlebotomy. So the need for phlebotomy was coming down. Now, Dr. Ankit, how do you target that? What should be the cutoff where you sort of decide about phlebotomy?
So generally, the target that we keep is a hematocrit of 45%. Either once or twice weekly phlebotomy is required on the initial phase. Once we reach a target, probably we can cut down on the phlebotomy and continue on hydroxyurea. Or if the phlebotomy is not required a lot, because the patient, if patient is not symptomatic, you can just continue on hydroxyurea.
So this patient also had the requirement of phlebotomy gradually decreased, and the hematocrit was varying between 47 to 55%, and spleen regression has been marginal. Dr. Pankaj Tantia, like you see the spleen going down and the phlebotomy. So what do you tell your patient if this patient has been diagnosed as polycythemia vera? What do you tell them? For how long this patient needs to take the treatment and what precautions he need to take?
Sir, I will first see the marrow biopsy report whether he is having myelofibrosis or not. If he is not having myelofibrosis, I will tell him that you have a very long life. It is not a kind of a it is a kind of a blood cancer, but in previous time it was never taken as a blood cancer. So it is a very benign thing, and you should be confident about your disease. You have to take your medicines daily on regular basis, especially aspirin. And don't think of that you are a young patient and you are taking aspirin, the drug which has been always been taken with the cardiology patients only, as your blood is generally thick. So you have to take the aspirin daily. So that I would advise.
No, I think very right. Dr. Pankaj has given very good message that a simple tablet of aspirin, it prevents lot of thrombotic episodes, and it prevents and it saves lot of lives. I remember my experience in 2007. Somebody has knocked my door in the night around 9:30, and he was sent from some outer place, and he was told that you have got blood cancer and you have risk of thrombosis and you may die anytime. So with that fear, he came to me, and this fellow now 13 years, he is sailing through well. So these MPN diseases are not bad disease. In fact, the patients pull on for years together, and the treatment is very simple. Only thing, you need to diagnose them properly, and you need to take help from the experts so that right treatment can be started at right time. The target hematocrit has been mentioned, and may I ask Dr. Jitendra that Dr. Jitendra, is there any harm of patients are feeling problematic that if I donate too much of blood, I will get weakness? So how do you manage the phlebotomy, and what is your target? What are the drawbacks?
So the target will be, as Dr. Ankit has rightly pointed out, should be less than 45. The ideal target range will be 43 to 45. And the patient concerns are right that yes, the patients are losing some sort of nutrients when they are going again in phlebotomy. Like iron deficiency is a common problem with these type of patients. So that has to be kept in mind, and otherwise it is a safe procedure to do.
Yeah, I think that is very important. That many times, yeah, Dr. Pankaj, you have some point?
Sir, I want to add on one thing. Patients generally who go for repeated phlebotomies, they usually have iron deficiency, and chronic patients have iron deficiency anemia for a long time, and they have symptoms regarding that, koilonychia and other symptoms. If patient is having problem with these kind of things, then we even have to give sometimes iron to that patient. But till now, we have not given any patient, but in books it has been written that patient have symptoms like koilonychia and other things.
So for this patient, he was on hydroxyurea, but he still needed phlebotomy, and he was not happy. I was also not happy. And at that time, interferon was there, and Dr. Vishnu has already mentioned about the role of interferon. So we had given PEG interferon to this patient, and which showed very good control. And the interferon was given for 6 months or so, and then he was continued on hydroxyurea and aspirin. So we will not discuss about the interferon part here. And in December 2014, the requirement of phlebotomy increased from, in fact, 3-4 times in a year to 12 to 14 times in a year. And this patient, based on the high requirement of phlebotomy, the Jakavi was available at that time from Novartis, and we were lucky to enroll this patient on Jakavi. And I'm thankful to Novartis for supporting us with the Jakavi with various schemes. So this patient was started on Jakavi, 20 milligram daily, and the phlebotomy required significantly decreased. And then he is currently on 25 milligram for almost 5 years, 5.5 years plus now. And of course, he's a retired army person, so he takes Jakavi irregularly based on the supply. But twice he has been elected for the Sarpanch in his village, and the liver spleen has regressed, and he is sailing through excellent quality of life. So 13 years on treatment with good quality of life, never required hospitalization, and sailing through excellent quality without much of side effect and issues. So, Dr. Jitendra, may I ask you that what is your first line treatment and what is your second line treatment? If Jakavi is effective, can you use this as first line treatment?
So the data doesn't show any benefit on first line.
Perfect.
So if the patient is intolerant or is not responding as per the target, so in those cases only we can give it.
Right. So the recommendation is that Jakavi and this expensive molecule is to be used as second line. And if the patient is resistant, when the hydroxyurea is not working, or the patient is not tolerating hydroxyurea. Dr. Pankaj Tantia, did you in your practice ever encountered a patient who is intolerant to hydroxyurea?
Yes, sir. I have encountered a lot of, sir. I want to clear one more thing. Patient who is having massive splenomegaly with polycythemia, he should not be taken only on phlebotomy, because phlebotomy never decreases spleen size.
Yes.
So either we should use a combination of hydroxyurea with phlebotomy or hydroxyurea.
Right.
Hydroxyurea, if as far as hydroxyurea resistance or intolerance is concerned, we have seen a lot of patients regarding this. Some patients have ulcers on the foot, a very big ulcer, so we have to stop hydroxyurea immediately. Gastric ulcers are very common, and patient usually lend himself into cytopenias, so we have to reduce or stop the hydroxyurea immediately.
Perfect. Thank you so much. So anemia has already been mentioned by Dr. Jitendra that because of the repeated phlebotomy, patient may develop iron deficiency anemia, and partly the rise in platelet could be because of the iron deficiency anemia. And ruxolitinib tips we will not discuss in this discussion. Leukemic transformation has also been discussed. And next we come to the case 2. So that was about polycythemia. Next is 45-year-old male, and this person has weakness, fatigue, and other constitutional symptoms. And he was having progressive splenomegaly since 2003, and he came to us in June 2011. The liver was 5 centimeters, spleen 15 centimeter. This was the hemoglobin 10, WBC count 16,000, platelet 362, and he had shift to left, monocyte, metacyte, and atypical cells. Bone marrow was done outside in 2004, which was suggestive of hypercellular marrow. Megakaryocyte series raised. Dr. Shashi has very well mentioned and very much stressed about the megakaryocytes, and this fellow had moderate fibrosis in June 2004. And this fellow came to us after 7 years of diagnosis. When he came to us, the hemoglobin was 9.8, TLC was this, platelet count was 5,83,000, and he had 6% blast. Sonography was suggestive of spleen of around 10 to 15 centimeter, portal hypertension, splenic infarct, moderate fibrosis in the marrow, and JAK2 was negative in this patient. So now I'll start with Dr. Ankit. Dr. Ankit, can you suggest that if you would have been the treating doctor for this patient and he would have approached to you in 2003, what different thing you would have done at that time?
Sir, in that time he already had moderate fibrosis in the bone marrow.
Yes.
So probably that would have been pre-fibrotic or a pre-fibrotic MF would have been DD at that time. I would have considered. I would have spoken to my pathologist who had reported the bone marrow regarding the megakaryocytes morphology, whether any ATPI is seen in that or not, and on the basis of that, we would have definitely considered him regarding further management on the basis of the bone marrow report.
Perfect. I think that is very important. And if we see the things clearly, the disease gives us adequate time. This patient is symptomatic and going to doctors since 2003. Probably we could not identify the right problem at the right time and we could not address the issue. So this patient had progression of the disease and he came to us after 8 years. He was sailing through with this large spleen, but probably the diagnosis was not made properly and he was having a lot of difficulties in reaching to the health center. So this is the importance of our training, our teaching, that we identify the problem at right time and we have the right treatment available for them. So when he came to us, we started with hydroxyurea, blood transfusion, supportive care, and this fellow required 20 units of blood transfusion in 6 to 7 months. The ferritin again went high, and because of the transfusion, he had other iron overload related issues. So I will not touch upon the treatment part, but he was later on put on Jakavi since he was from a BPL family and it was tough for us also to support with Jakavi, but somehow we managed and Novartis agreed to give this patient almost free Jakavi support. So he was managed with Jakavi and the blood transfusion requirement increased, spleen enlarged, portal hypertension, the blast cells also increased, and then ultimately this patient died in fact. So Dr. Pankaj Tantia, you have done bone marrow transplant sitting in Bikaner. So may I ask you that if you would have been treating in charge in 2003, would you have considered this patient for a transplant?
Yes, sir. This patient should taken for a transplant. Allogenic transplant should be done in this patient, sir.
Perfect. Again, so that is the importance of early diagnosis and proper referral. We lost this patient with 45 years of age, and this fellow was not able to work for 11, 12 years after the diagnosis. So, in fact, looking to this, there lies the importance of understanding the things and timely referral and making the things available to them so that he could have saved and his life could have been more quality life. This has been shown, in fact, the myelofibrosis treatment based on different risk factors. We will not go into the minor details. This has been mentioned by my previous two speakers, Dr. Vishnu and Dr. Lalit Sharma, that different mutations, but this all is available to very high-end centers and this is not available to people sitting in small towns, in fact. So, very small discussion for 2 minutes on case 3. This is a young girl, 18-year-old female girl, and she was having headache, weakness, fatigue. She was detected a high platelet, and when she came to us in July 2014, the platelet was 10 lakhs, spleen was 4 centimeter, liver 3 centimeter. So at this age, the girl, when she was supposed to be in the college with all enthusiasm, and she was detected to have this type of problems, blood cancer. So bone marrow was done, and the bone marrow was suggestive of megakaryocytes increase and hyperlobated macro megakaryocytes. So the diagnosis was query ET. Dr. Samir Agrawal, can you suggest that what are the features where the common doctor should suspect erythrocytosis or ET-like problems?
Sir, thrombocytosis is a pretty much common feature that we see on CBC.
Right.
And we see in the peripheral blood also, obviously on a peripheral blood film. So what is important is to know the history. As we know in this patient, there is a splenomegaly and hepatomegaly. So that point, that is a very interesting finding because they can be most common kept in mind because 18-year-old girl, nobody usually thinks of a ET in an 18-year-old girl. It usually is seen in a 50 or 60-year-old patient. So that has to be kept, so keeping this differential diagnosis, with other findings, because hemoglobin is normal and TLC is also low and platelet is high with organomegaly, then ET can be suspected, and other further bone marrow is obviously it is done in this case. So
I think even the
done.
symptomatology, if we see, she had headache and fatigue also. So probably she had thrombocytosis related symptoms. And JAK2 was positive in this girl, and she was started on hydroxyurea. And the bone marrow, again, we will not discuss that whether this is compulsory or voluntary. And these are the data. We will not go. JAK2 is positive in almost 50% of these patients. And this is her details that she was on hydroxyurea. But being a young college girl, she was not coming to us regularly. And she was coming off and on. But touchwood, she was doing well. And the hydroxyurea we kept up to 2 gram daily. And in between, she had a lot of lapses. On regular hydroxyurea, the platelet count was around 5 lakh, but lastly it was around 20 lakhs. So, Dr. Jitendra, how do you manage such high platelet count? Is aspirin safe at this platelet count, or any other suggestions?
Sir, actually at this point we have to do cytoreduction also along with aspirin. And since she is JAK2 positive, we can use Jakavi. Second thing regarding platelet, if platelet count is 5 to 10 lakhs, probably ecosprin do work better. But as the platelet count increase more than 10 lakhs, actually the patient can have acquired von Willebrand deficiency. So platelet, antiplatelet should be given at a lower dose to the routine patient.
So that is very important take-home message. Dr. Jitendra says that if the platelet count is more than 10 lakh, you should not give aspirin. We may do more harm than benefits. These are the thrombotic events. Why we are worried about the ET, essential thrombocythemia, that there can be stroke, there can be transient ischemic attacks, there can be renal artery or venous occlusion. We can have coronary artery ischemia, pulmonary embolism, deep vein thrombosis, ischemia, and there can be increased pregnancy loss. And many of these patients of polycythemia vera, many of the patients of ET, they go and present to the neurologist with stroke and transient ischemic attack. So we get a lot of referrals from neurologists that they are doing the CBC and they are documenting that this fellow has got a thrombosis. So these are the predictors. We will not go into the details of these predictors. These models have been there. So take away messages. We all are at take home only. So I'll say take away messages. MPN is not common in clinical practice. Careful history, which is very important. Careful history, detailed clinical examination, especially the organomegaly part. Doing a proper CBC, doing a proper PBF, which is of utmost importance. We don't need any high-end investigation and molecular test at each step. We need to be very clear that the simple test will give us good clue. Bone marrow aspiration and biopsy is needed. I'll emphasize that most commonly biopsy is being missed at peripheral part. So biopsy remains of importance. Molecular based diagnosis is important, especially when we want to see how much the person is going to survive and what type of treatment is to be offered. So the complete workup is not without molecular based diagnosis. And I'm happy that in Jaipur and in many parts of Rajasthan, Bikaner, Kota, the molecular based diagnosis is available. It is being outsourced to different labs. Accurate diagnosis based on different criteria facilitates the prognostic value and disease characterization. And we should not be surprised because there are a lot of recent advances coming. A lot of new molecular markers are coming and a lot of new scores are being coming. So be ready that we change our minds as and when needed, and you may get some more information, some more molecular markers the moment I finish up this talk. So I think with this I end up, and I thank all the participants, NHM Rajasthan, Mahavir Cancer Hospital, and everyone. And may I request Manish ji, if he is there, Dr. Ashok Jain, if he is there, to provide some support from NIH for the hematology part. Dr. Manish ji, are you around there? Manish ji or Dr. Ashok Jain, we have two big people, big giants with us, in fact, and they are from the government of Rajasthan. And I'm thankful that they are taking keen interest in hematology, and they have come up with blood cell in government of Rajasthan under the NHM. And the point to be noted that many times what we discuss, what our patients need, what facilities are needed, the government is not knowing about those facilities. And many times the non-medical people, they decide about the facilities which is to be made. So I think Dr. Ashok Jain Saab and Manish Chaudhary both are not able to unmute themselves. Any other comments from Dr. Ashok Jain sir? Are you there? Dr. Ashok Jain sir, may I request you to unmute, please? May I request the backend team to unmute Dr. Ashok Jain, please? Yes, sir, you are unmuted now.
Sir, the things which will be required in case of such patients and blood disorders, we will provide all the necessary support by giving all these necessary support. We will try to put these support in our annual PIP, sir.
So I think that is big assurance, and thank you so much for your kind words, sir. And we are thankful for providing support for thalassemia, hemophilia. The hemophilia factor 8 is available even in small areas of Rajasthan with the support from government. And thalassemia, sickle cell also is being boosted up. May I request you to, sir, say a few words about the thalassemia and sickle cell and other projects which blood cell is taking up?
Sir, we are going to screen the thalassemic patients in 4 districts as a pilot project. The total number of this screening will be 1 lakh, around 1 lakh ANC cases and 1 lakh the college going students. After getting the results, HPLC and getting the results, we would work to expand this work on the other parts of the state. So,
thank you so much, sir. And how about the laboratory backup, sir? Is there any proposal or plan to have a high-end molecular lab in Jaipur?
Sir, at present, we are going to start CBC and HPLC in these 4 districts only, sir.
Perfect, sir.
Sir. And the single and double filter, the essential medicines which are included in our program are freely given to all patients, sir.
So I think that is also big support. Sir is mentioning about it. Yes, sir.
Sir, we have 6 day care units in our old medical colleges, particularly in Jaipur, Kota, Bikaner, Udaipur, Ajmer, Bikaner. So we are going to start 6 daycare centers. These centers are properly working, and we are also providing the essential medicines as and when required to all these patients, sir.
Thank you so much, sir. Like you have mentioned about the factor 8 and the thalassemia support. So MPN also is a big group, in fact. So we request that you consider myeloproliferative neoplasm, and we keep generating the awareness about the educational activities, and the management remains expensive. So I'm requesting you that whenever possible, because government machinery you understand better, whenever possible to consider the drugs being used for myeloproliferative neoplasm, because these patients survive for a longer period, and the transplant other complications can be omitted if you treat them properly.
Sir, we will sit together and we will consider these medicines, and we will provide these medicine by EDL group, sir.
Thank you so much, sir, for your kind words, and we truly oblige with your presence and your kind words. Any other faculty wants to comment anything related to today's activity, because this is our first beginning, and we plan that in future also we connect to various medical colleges through the digital platform, and we all spread the awareness about the hematology and develop the network of hematology in Rajasthan. Anybody else wants to comment or say any words here?
Sir.
Yes, Dr. Meenakshi, you want to say something?
Very good presentations by all the 3 speakers, and very informative session. And actually, it was, I mean, the flow of the entire session was so good. The way it was conducted, I must congratulate you, sir. And let's look forward for more of such kind of events in near future.
Thank you so much, Dr. Meenakshi Sharma, for your kind words, and we expect more and more contributions and collaboration with open-minded people like you and other faculty members.
Thank you, sir.
Thank you.
Video. MPN.
So now may I hand over the mic to our organizers. So I think we all had a good discussion and we all had practical points being raised by various faculties, and more than 100 students have been watching this recording, and we all feel that these patients of myeloproliferative neoplasm will be doing better and better. So I think we all have seen these in different presentations, and once again I'm thankful to all the faculty members. Onco next.
सिकल सेल का एक वीडियो है.
So I'm thankful to all the faculty. I'm thankful to Novartis Oncology for their support for this program. And I'm thankful to all the participants and audience who have been with us. And Vikramji wants to play one more video here, if you all can see. This is related to sickle cell.
आवाज आ रही है? पैसे मिलेंगे. लैपटॉप से आवाज उसकी आवाज को
So with this, I thank all the participants, Professor Ashok Jain, Dr. Satish Verma ji, Dr. R.K. Tanwar, and all the faculty members, Manish Chaudhary for connecting us, and I thank all the faculty members. And with this, we end up, and I wish you all a happy Christmas and happy New Year to all of you. Thank you so much. Have a nice day. Have a nice nice weekend. Thank you. We all can leave now. Thank you so much.
Thank you, sir. Thank you for such a nice webinar. Thank you, sir.
Thank you. Bye-bye.
Thank you, sir. Thank you, sir.
Good day.
Thank you very much.